Please, Caroline.
Thank you. I want to thank everyone for having me here. Absolutely, Dr. Mortakis. It's an incredible honor. It's been a dream of mine to come to Greece since I was a little girl, and it's amazing for me to be here. I'm very excited to share this talk with you because most of you have never heard of it or just have a little bit of an idea about our topic of vaginal rejuvenation, also known as cosmetic gynecology, also known as aesthetic gynecology, and the word and the name I'm trying to really promote is regenerative gynecology. Because just right off the bat, I want to emphasize that nothing we talk about is about beauty or making it look different. That's not what this is about. This is the whole field is about improving our function as women as we go through our lives, each and every stage of the differences that we occur as we go through life. So I'm trying to figure out this thing, which way I go. There we go, I got it. So the very first thing that I like to discuss is when we talk about altering female external and internal genitalia, is it mutilation? Is it not mutilation? And the biggest controversy is, and this is what pops in all of our heads, oh, this is nonsense, who needs to touch it, that everything's normal. That's all true, but we have to talk about the changes that occur and improving our female function. A lot of the situations and symptoms we don't speak of. So, unfortunately, the biggest issue is the World Health Organization that describes any alteration of the external genitalia as mutilation. And that is a concept that really has to be weakened and changed. What we know is that more and more patients are requesting changes in their external genitalia, and again, viewed as aesthetic. It's not about aesthetics as I go on, and I'll explain more. The reason why it falls into aesthetic category or cosmetic category is because of the tools we use. Using lasers, using platelet-rich plasma has always been viewed as a cosmetic approach. So that's how we fell into that category. And unfortunately, it gives it a misconception that personally drives me crazy, as you can tell. So the ethical issues about are we mutilating, we have to keep 4 particular issues in mind. The first is non-maleficence. We're not going to do any harm. We take an oath as physicians. And the bottom line is that it is for a functional reason. The other is that the patient has autonomy. We are not operating on 14-year-olds. We are only doing these procedures on patients who are adults and can make an informed consent to do any alterations. And beneficence, it's going to do a good procedure. You don't just say, oh, I heard about this, I'm going to cut off your labia. You have to know what you're doing. As a physician, you have to be trained appropriately. And also, the physicians ourselves are going to continue with evidence-based medicine and get proof in clinical trials of the safety and efficacy. And just as a physician, it doesn't matter what a patient asks you to do if it's not right for you, and if you're just doing it for money, that's not a good reason. Then the next topic is what's normal, what's not normal. Everything is normal. There's no, unless it's a congenital abnormality, everything, any other variation is normal. However, the cultural variations are interesting. In Japan, the picture up in the corner is actually beautiful. It's a butterfly pattern, and that is viewed as beautiful. In the Western world, women do not like that, and they want the labia to be smaller and hidden by the labia majora. So in Africa, they also do rituals of pulling down on the tissue. I'm going to quickly go into the evaluations. In 1899, the first described by Waldeyer, he showed that the normal labia minora would only be 2.5 to 3.5 centimeters. However, another study done by Lloyd showed that the average is 2 centimeters, with the variation being anywhere from 0.7 to 5 centimeters in diameter. So what's our normal anatomy? We all know. I'm not going to waste time on this. The majority of us are gynecologists. However, there are a few things I want to point out which will come into significance as I continue my talk. One is that the clitoris is actually much larger and much more involved than what we see just as visibly on external anatomy. We know that there are crura of the clitoris that are analogous to the penis, and it has the same number of nerve endings, and that would be 8,000 nerve endings in the tip. And it's the only purpose of our clitoris is for sexual arousal. But what we need to know is that it's not only in the tip of it, but also in the crura. There's sensation involved. So it's the most common method of self-stimulation and orgasm. And once again, we want to depict here the significance of the vestibules, the Bartholin's glands, the Skene's glands, which all come into play. And vaginally speaking, I want to point out as I go on that we must keep in mind that the vaginal opening, the outer 1/3, has the highest concentration of musculature and nerve endings. The inner 2/3 have very few nerve endings. And the reason why I bring this up is because in the use of lasers, if you're using the CO2, you do not need to use any kind of numbing agent. The patient can come in, as the good Dr. Gold mentioned, they can come in, have the procedure, and walk right out. The total downtime from intercourse is 3 days on a laser. No problems. So what happens to our inner vagina? It changes during intercourse, it elongates, and it's usually before menopause, it is elastic and extends. However, post is quite different, as we know. The G-spot is another important issue that I want to point out. Does it exist? Does it not exist? And we know that in the 50s, the first study that was done showed that there wasn't a G-spot, but the Italians, my good people, came running behind and said, yes, yes, there is a G-spot. And most women pretty much know that there is an area in every woman, whether they know exactly where, in the anterior wall of the vagina that has increased sensation, and you always know when you find it. Next is vaginal aging. What's going on in a woman's body as we age? So the first issue that we encounter is childbearing, where following a pregnancy and a vaginal birth, sometimes there are no changes. Women do look like they've never had a child. Yet other women with an episiotomy or with a tear or just from the overdistension of the vagina, I kind of describe it in those women as an overstretched rubber band. It doesn't quite snap back to the way it was. So returning that back to a brand new rubber band is our desire and our effort with the lasers. The results of feeling a wideness and loss of sexual sensation, it occurs with that laxity. And the other area that changes is our mons pubis. As we age, it increases in fat. Women hate that fat pad that develops. And the labia majora lose fat and become elongated and saggy and can get in the way of clothing, as well as the labia menorah enlarging over time. There's, of course, the decrease in estrogen levels that then lead to our atrophy, which for the gentleman in the room to describe and help you understand what it feels like being a woman postmenopausal, having intercourse, it feels like a hairbrush. It no longer feels pleasurable. It feels like you're using a hairbrush. So it's very uncomfortable and in many women close to impossible to tolerate. So the effects on our bladder neck because of lack of estrogen and because of the changes in the vagina from childbirth, we have urinary incontinence. I call it urinary incontinence, stress incontinence, urge incontinence, and frequency and urgency. All of those changes can be treated with the procedures that we do. So overall, what are our procedures? What are we talking about here? We're talking about fat filling of the labia majora, and from the mount of Venus, the vertical or triangular trimming of the labia minora, the partial unhooding of the clitoris, vaginal tightening, the hymenoplasties, laser vaginal rejuvenation, and other energy-based procedures like radiofrequency, which I'll go into, and of course, platelet-rich plasma procedures such as the O-shot and the wing lift, which I will describe. How do you select your patient? Typical as any other medical condition. You want to make sure you have your history, your allergies, and what's going on. Now, specific for these procedures, you want to evaluate skin elasticity, evaluate muscle weakness, and discuss the operation in detail or the procedure in detail, and any possible complications. Another critical fact when it comes to the surgical procedures involved here or any of the external procedures with the laser, you want a before picture, and it's critical and it's your only protection should anything change or the patient claim, I see no difference. Clearly, you can show them the before picture. Side by sides, before and after, will explain the whole thing. I'm going to go into the surgical procedures, and the other critical point I want to make here is I do everything in my office under local anesthesia. I don't take my patients to the operating room at all. I'm not going to go extensively into labiaplasty because our next lecture is about labiaplasty, but I'm sure we will hear all about the different methods. The labia majora aging, as you see here, the outer lips become lax and they truly get in the way in trying to do sports or even in intimate moments. So it is a annoying result of aging. The cosmetic deterioration, loss of the subcutaneous fat, the collagen degrades, and we have a variation of our fat distribution. So one way of treating this in the past, we no longer do this, was to actually reduce the skin and cut it out and reapproximate the edges. We don't like to do this as much anymore because of scarring. It's just not particularly comfortable for the patient. Clitoral unhooding becomes important for patients who are completely anorgasmic or really, really have a hard time achieving orgasm. That is not aesthetic. We're not trying to make it look prettier. These women cannot have any intimacy with pleasure. And so having the clitoris slightly unhooded, and you have to be careful, of course, not to overcorrect, because then there can be constant stimulation, which is the opposite problem. But mostly, just trimming a little bit of the excess hood can help these women actually feel something during intercourse. Postoperative facts, the critical, and this is critical in any of these procedures, I tell my patients not to have any penetrating intercourse for anywhere from 6 to 8 weeks. I see these patients every 2 weeks because they need that constant reinforcement of not yet, not yet. No, I know you're feeling better, but not yet, because the tissue is sensitive, it's thin, and you want to make sure it is very, very well healed before they have that kind of activity. Contraindications are the current any infection, any current gynecological disease, smoking. Body dysmorphic disorder, BDD, is a very serious condition. Patients will come in complaining of something that does not quite sound logical to you, especially looking at them, and therefore you have to avoid those patients. They are impossible to please. You will never, ever make them happy. Anyone with serious sexual dysfunction, history of sexual abuse, again, you want to make sure these are relative. There are no absolute contraindications. Unrealistic expectations is dangerous, so you have to make sure you explain to your patient what they can expect. Regenerative procedures are fat grafting, energy-based procedures, and my favorite, platelet-rich plasma. So for the labia majora, you can aesthetically improve that with fat grafting. Typically, this is done with minor liposuction done in a small area, maybe the outer thigh or the mons pubis in particular is a great combination because you're killing two birds with one stone. And it is a matter of filling the area. Literature is scarce on whether or not this is of great success, but the patients truly are very happy with it in the end. And the way we do this is with a downward in retrograde injection of the fat using cannulas in a 22 gauge blunt cannula and retrograde fill, always because of danger of blood vessels and fat emboli. But the end result is lovely. A lot of patients like it because it also minimizes the appearance of their labia minora. So G-spot amplification was first described by Dr. Matlock in 2001. Unfortunately, he was and is using hyaluronic acid and or coapatite, hydroxy calcium, and with that, it was very dangerous, and what happened was there are granulation formation. So personally, I never put any hyaluronic acid in the anterior wall of the vagina. That's my personal preference. I avoided it at all costs. The only kind of HA that you can use is one that does not have cross-linking. Maybe the new PGA will be promising. I don't know yet. So basically, vaginal tightening, we are using the lasers because we have documentation that indeed the patients do feel a difference. So I'm going to speed through all of the laser issues. I'm just going to stop here for a second and describe that we do have now the radio frequency devices. I'll skip the laser. And because we went through this, RF is very exciting new field. Up until now, we had only monopolar type of devices. However, we are now getting bipolar devices that are able to treat the entire vagina circumferentially all at once. Whether or not they have adverse events or whether or not they're effective still remains to be seen. A lot of literature has to be created here. And again, same kind of prerequisites and contraindications. No HPV when it comes to heat or energy-based procedures. They must have a negative HPV for at least a year before I will use any of the lasers on the vagina. PRP. PRP is a incredible procedure that we can use. Now, the way I describe it, when we're little children and we scrape our knee, yellow fluid comes out, a scab forms. The scab falls off, and we have nice new pink skin. So doctors said, what is that yellow goo? What is it and what's in it that helps us create new soft tissue? So they analyzed it, and they saw that it contained activated platelets. The platelets, when they come into contact with injury or inflammation, open up and release the alpha granules that contain growth factors. Every growth factor you can imagine for the development of soft tissue. So it can grow endothelial cells, it can grow fat cells, it can grow nerve, it can grow collagen, increase fibroblasts, and one of the key aspects of PRP is that it also has chemotactic effects. It is it's brilliant. It's the elixir of life. In our body, it will release the chemicals and bring the stem cells to that injured area to build the tissue that's needed there. Does that make sense? So it's incredible, the capabilities of platelet-rich plasma. It can be added to any surgical procedure as fertilizer to help the healing of absolutely anything that we do in any aspect of medicine. And it has been used extensively in sports medicine to inject into joints, and now we're using it, hallelujah, in the vagina. And it is showing incredible promise. Together with the laser, I call that the laser-enhanced O-shot, or the trademarked procedure using platelet-rich plasma into the anterior wall of the vagina. And with that, the combination improves our treatment of urinary incontinence immensely to 90%. All right. So it is the elixir of life. The other critical important factor I want you to take home is that there are over 8,000 written articles on platelet-rich plasma used in extensive modalities in medicine, and there have been no long-term adverse events using platelet-rich plasma worldwide. Okay? It can be combined with hyaluronic acid, and it's been shown to improve bone development. So it can be used in the labia majora. And now to go into, this is an article one of my patients wrote, chronicling every step of the procedure that I did for her and out for 3 months. She was young. She was around 35 years old, and she had difficulty orgasming because she was on antidepressants. So with the shot, she was able to become intimate and enjoy her time with her husband. The area that we are injecting the platelet-rich plasma is simply in this O spot, the area right at that point where it is about a centimeter or so in from the hymenal ring at the level of the urethra, but not into the urethra. The procedures that just a simple white paper that we did in order to find out at this point is, and I'll explain why we don't have more clinical trials yet with PRP, but with our white paper showed that we had an improvement in the female sex distress scale, significantly dropped 10 points. One of them, number 3, is important because hers got worse. So we asked her, why do you think it got worse? And she said, because her husband couldn't keep up. So she wanted more intimacy, and he wasn't able to meet her needs. So she was more frustrated than help. Now, again, the platelet-rich plasma with the female sex function index also showed improvement. We can use the platelet-rich plasma also for lichen sclerosis. And what I want to point out about PRP and literature is that PRP is not a drug. It has no pharmaceutical companies backing the research. In order to do a research study and to pay for the analysis and to pay for the patients to have free care and transportation, it's extremely expensive. And there's nobody supporting this kind of research, because it's not a drug. And the centrifuge companies, there's millions of them, so they're not paying for it either. So it only comes out of our own pocket as physicians. So Dr. Charles Runnels, who invented the O-shot and who's been doing this research on lichen sclerosis, has a company, a trademark, and I pay money to him so that we can have the research done. But that's the only way it's getting done, with platelet-rich plasma. So again, the study has been done by Dr. Goldstein in Washington, D.C., showing incredible improvement in lichen sclerosis before and after. And you can see the increased collagen and the decreased hyperkeratosis with the injection of PRP directly into the lichen. And this is without laser. So I think that the study needs to be done PRP only, PRP and laser, and steroid, and compare the results. So the PRP injection benefits are greater arousal with clitoral stimulation, tighter introitus, increased arousal in the G-spot area, pink younger skin, it improves the color and the tone of the tissue, increased sexual desire, and better orgasms. And I know I did that very quickly, but I wanted to give you an overview and a little bit of an introduction to our special field. Any questions?
Thank you very much.